Good evening, professors and colleagues. It's my pleasure to be here with you in the annual Dialysis Conference and NephroChamps. I will discuss today in brief how to choose a dialyzer and what a clinician must know. So our agenda will be focused on the basic components of a dialyzer and when a dialyzer is innocent and the functionality in depth like clearance, KOF, and transmembrane pressure. Dialyzer fiber configuration and rheology, the hemodialysis membrane, and requirement of a dialyzer for best or optimum hemodiafiltration. There is no too much publication on that field, so we will use our clinical experiences over the last 30 years on hemodialysis. A dialyzer specifically is characterized by the 6D, which means that a dialyzer is a medical device with a downstream of blood flow should be optimized. A dialysate and the blood matching should be optimum, and the dialyzer, if chosen perfectly, it will drive these sessions and it will increase the dose of dialysis and should be have the diffusive and the convective transport up to the optimum level to induce the patients clinically as well as a dialysis session perfectly. So the dialyzer has a 6 days, it's a medical device with downstream of blood flow, dialysate and the blood best matching. It drives the sessions of efficacy and dose of dialysis is dependent largely on the device with enhanced diffusive as well as convective transport. For example, if you have the dialyzer with a specific ultrafiltration coefficient, the nephrologist can control that either to go with real ultrafiltration or to induce organ stunning by higher ultrafiltration. So by the all, is the dialyzer is a medical device that a nephrologist could use and drive that to have a safe and efficient dialysis session. When a dialyzer is innocent, if the nursing is doing imperfect priming, inadequate anticoagulation, if it's small for the patient weight, if it's low blood flow rate, QP, or there is a recirculation in the vascular access type, or the dialysis time is short. So in all these cases, the dialysis adequacy is not related to the dialyzer, but it's related more on the techniques and behavior of the dialysis session. So it's a device-related factor or nephrologist-related factor, and sometimes related to patients-related factor, mainly in the vascular access. So when a dialyzer is innocent, in particular, we'll focus on recirculation. We have two types of recirculation, either the short loop recirculation and long loop recirculation. While the short loop is related to the vascular access, it's a very common, and long loop is related to cardiopulmonary recirculation, and it is sometimes found in patients with high flow arteriovenous fistula. So access recirculation, either or long loop cardiopulmonary recirculation, can induce inadequate dialysis by the recirculation process. We'll take here an example of the systemic tissue enriched with toxin not be reached with the dialysis station by the cardiopulmonary axis. So the blood flow returning from the patient to the heart is pushing forward again to the systemic circulation. But if the arteriovenous fistula flow is very high, bypassing the systemic tissue, so systemic tissue enriched urinary toxin is not accessible. So the dialysis adequacy decreases markedly. Also, if the systemic vascular access here, arteriovenous fistula, is high, flow like more than 1 liter or 1.5 liter, even more, 30% of the cardiac output, so there is a risk of heart failure as well. So please, it should be mandatory that the blood flow inside the fistula should not be exceeding 30% of the cardiac output. Nominally, as well the access flow recirculations, meaning that in, out, and in blood flow recirculating again, and this is induced dialyzer clotting, clogging, and lower performance. So here the dialyzer is as well very innocent. Dialyzer perfectly should have a past convection because convection enhances the removal of middle molecules. So dialyzer with higher ultrafiltration coefficient should be used in high flux or in hemodiafiltration to have a water molecule removed besides the middle molecule, so optimizing that against a transmembrane pressure. So any dialyzer choice should have both the convection and diffusion criteria to be optimized. The surface area defining the dose of dialysis, so bigger surface area is required to achieve the optimum dose in adults. It's usually above 1.6 in adult patients square meter surface area. If you are using hemodiafiltration, larger filters will be required to achieve the high ultrafiltration and substitution. Always the clinician judgment is the cornerstones. The right surface area and the right time, right convection is important factors in choosing the dialysis. Not only dialysis, as we also discuss multifactorial adequacy of dialysis, you should have a high flux, improved anemia, control of nutrition, control of blood volume, as well control of blood pressure. So dialyzer is just a device where an adequacy is more scenario. Always personalize the hemodialysis patients, taking in account the risk assessment planning and monitoring. Choose a high-risk patient to have a hemodiafiltration, for example, or increasing the dose of dialysis by bigger surface area. You can either individualize your patient by the dialyzer surface area, dialyzer type, sterilization type, and dialysate composition as well. Looking in depth inside the dialyzer, dialyzer flux or permeability, it's an old identification was based on just the KOF. Nowadays, the dialyzer identification or permeability depends on the beta-2 microglobin and sieving coefficient criteria. Subsequently, the dialyzer flux and protein leaking membrane depend on the water permeability, beta-2 microglobin removal, as well as albumin parameters, sieving coefficient. Looking in depth in KOF and KOF maximum, the KOF or dialyzer ultrafiltration coefficient is defined by how much volume of fluids is removed per transmembrane pressure, while the A is the surface area of the dialyzer. The ultrafiltration coefficient of dialyzer is not a fixed value. It depends largely on the transmembrane pressure. So sometimes it's a parabolic, or meaning that you have an average of KOF against the transmembrane pressure. If the patient has a high viscosity or the filter geometry is changing, the KOF is changing. And it's never linear, it's only linear for water. But when you are using in vivo or in the patient blood, whenever the transmembrane pressure is less than 300 millimeter mercury, so the dialysis usually ultrafiltration is optimum. So beginning from 200 millimeter mercury and above, the transmembrane pressure will be higher and the efficacy of dialysis will drop. When you are using higher ultrafiltration rate, you have to use higher blood flow. So at a specific transmembrane pressure, you have a higher ultrafiltration rate against the transmembrane pressure. can overcome the KOF by increasing the filtration parameters of the dialysis station by increasing the blood flow rate, and this is importantly in hemodiafiltration. It's never linear, so it's parabolic. According to the transmembrane pressure applied, you have a specific ultrafiltration. Increasing the transmembrane pressure will drop down the ultrafiltration rate. So usually in this area is the maximum KOF. So the transmembrane pressure, with building up transmembrane pressure during dialysis, this will decrease the ultrafiltration rate and the clearance value by protein layer formation. So our job is to optimize the ultrafiltration in hemodiafiltration accordingly to the dialyzer KOF, and it's run automatically in the hemodialysis machine unnoticed by nephrologists. So how you can choose a dialyzer design and to improve the solids clearance by hemodialysis patients, and almost synthetic dialyzer should have a smooth inner surface. It's like an endothelium layer. Improving the flow of the blood flow inside the dialyzer with specific cycle arrangement, considering the velocity of blood inside, you are always seeing that the inner side of the blood flow is in the middle, and in the peripheral part, the blood flow is limited, while the dialysate has the opposite. It's increased in the peripheral and decreased in the central. So we have to optimize that, and the speed should be, by the flow pattern of the filters, should be optimum for a clearance value with matching of the blood as well as the dialysate at the same time. So the blood compartment with the Vmax or maximum velocity could be enhanced by specific design in the caps of the filters, and subsequently you improve the blood flow. These are very common. We can see that a lot of blood streaks usually due to stagnation of the blood on the peripheral part, and should revisit the blood flow as well as the anticoagulation. Coming back to the flux with the known high performance dialysis membrane or super flux, and it's commonly used in Japan with high performance, and its criteria depending on 5 classes. This additional definition of dialysis membrane flux, whereas it defines the molecules of beta 2 microglobulin clearance. The 5 types of the dialyzers is the optimum here is the maximum clearance of beta 2 microglobulin. So this is a superflux, and here 4th type, and this is the natural high flux membrane. So classification of flux or high flux dialysis membranes depending on the sieving coefficient as well accordingly to the Japanese classification to beta 2 microglobulin clearance. So this is a Japanese reimbursement system, and it's very important to notice that if you are doing a high performance dialysis, you should get more and more of the reimbursement system. So is it the correct time to use high performance dialysis membrane with an excellent biocompatibility, effective clearance of target solids with maximized pore size to increase the middle molecules removal, but still the albumin leak is below 3 grams per dialysis session. And increasing the surface area will improve the dialysis efficacy both in high flux dialysis as well in hemodiafiltration. As well, the dialysis membrane should work as well as endotoxin transfer barrier. So any endotoxins coming from the dialysate side should be protected to become inside the blood by the effect of the dialysis membrane wall. And you can induce that by different techniques. We can use that in vitro as well in vivo performance. Importantly, as well, the dialyzer is not only a fiber; its components is important. The blood flow pattern is as well is very important. With fiber number depending on the surface area, for example, if you are using 1.6 square meter, it's around more than 10,000 fiber for adult dialyzer, or around 3 kilometers of the total length of the fiber inside. It should be designed perfectly to improve the clearance, as well to improve the blood flow and see the physical performance of the dialysis filters. This is the smallest one I did. It's a new flux. It's a very, very minute 0.04 square meter surface area used in dialysis for the newborns. So the hemodialysis membrane, it's a physical-chemical criteria. The ideal membrane should be biocompatible, optimum ultrafiltration, characterized by excellent diffusive and convective, resistant to chemical and physical sterilization with an optimum permeability profile. So you can use it as high flux or hemodiafiltration at the same time. The membrane innovation to remove extra toxins with increasing the porosity, so increasing the blood flow as well, the increasing the pore diameter. It's a big word for a larger porosity of the dialysis membrane running now. The dialysis research on the randomized control trials had many bias before when you are comparing the low flux against the high flux dialysis membrane. I think nowadays all modern countries are using high flux, and it is either high flux dialysis or hemodiafiltration, so no way to return back to low flux dialysis. Considering the sterilization type, we have steam, radiation, and electron beam. And steam, you have an autoclaving or inline or direct flow steam sterilization. ETO is nowadays is not common in using when dialyzer used because it's allergic, while heat and radiation are the commonest now. While heat is the most applicable way of common dialyzers in the market, still, radiation has some important drawbacks of cytotoxic compounds released from the dialyzer and from the protein compound. So we always prefer heat sterilization. And if you are using heat sterilization, it is an autoclaving, which is the best to disinfect and sterilize all components of the dialyzer at 121 degree for at least 20 minutes. So the effect of sterilization is different. As we mentioned, we have to try avoiding that with ethylene oxide, and in particular, dialyzers component will be more toxic. And if you are going to use more perfectly the dialyzer in the right way, we have to decrease the hypersensitivity reactions. And hypersensitivity reaction is related to many of the components of the dialyzers. The safest way is to do a better priming technique to remove all the air, will prevent clotting, and removing all the minute particles inside the circuit, which is called distillations, so we can have more and more efficient dialysis. It seems that you need about 1 liter of priming, but it differs from design to design and membrane to membrane. So I think that 500 milli is efficient to improve that for the dialysis adequacy. Priming should be done both in the blood flow as well for the dialysis flow at the same time, so ensuring that all the minute particles that may induce hypersensitivity reaction should be optimum in that way. So do always priming, good priming to increase the dialysis efficiency and safety. Looking again into in depth of the membrane hydrophilicity, meaning that the inner layer of membrane facing the blood should be more hydrophilic, so prevent protein absorption. And if you have a protein absorption on the membrane, calling protein fouling, you will decrease the blood efficiency to matching the dialysate and decrease the efficient dialysis circulation. So more hydrophilic membrane is required, so it is a smooth like an endothelium. More hydrophobic membrane will induce clotting and protein fouling, decrease the overall dialyzer performance. And increasing the pore size will increase the permeation, while increase the hydrophilicity will improve the blood membrane contract size. So the dialysis membranes composed of a polymer, and the polymer could be a polysulfone, polyether sulfone, polyamide, but all of them have a layer called polyvinyl pyridone or PVP, which is the hydrophilic part. The dialysis membrane is asymmetrical, meaning that its inner layer is smaller pores against the outer, with the backbone of polysulfone, polyether sulfone, or polyamide. And if you improve the PVP particles inside the membrane, you will have a more smooth layer and a more hydrophilic component and less thrombogenicity. So this is a electron microscopy, atomic force microscopy, inducing here the smooth and the roughness inside the dialysis membrane. And if you have using a dialyzer fiber with an inner lumen of 200 micron, you will have much better blood flow inside with less fiber clotting or fiber heating. And if you are using less anticoagulation or very narrow fiber, you may have not smooth surface, and this will induce fiber clotting. This is the technology of computer simulation. You can improve that efficiently, and you can use that on a computer model to see that how much is improved. And you know that the thrombogenicity is a hallmark of the dialyzer, and we should avoid that completely by more and more biocompatible dialysis membranes. So the dialyzer Viper geometry and microindulation technology, this is the straight fibers is not the best to choose, while microindulation of the fiber makes no dead spaces around the dialysate and the blood matching. The fibers are microindulated for better blood to dialysate matching, and if you are using the microindulation, you improve the fiber arrangement and a fiber blood to dialysate match. You got the maximum performance criteria on that. So these are straight fibers, however, the microindulation improves that. Coming to how to choose a dialyzer, you have different fibers material on the flux, you have different surface area, different biocompatibility, different sterilization, best rheology, as well clearance. You have a different microindulation technology, like this very nice gird, where the curling of the fibers when the swimming pool will not have a dead spaces other than these straight fibers that make a lot of dead spaces between blood and dialysis. Another technology is the performance enhancing technology, where a spacer yarn are used, and spacer yarn increasing the clearance as well and could be measured by flow design, where the spacer yarn or the microindulation improve the blood flow to dialysate matching rather than the standard type. It's only a dialyzer. When you are using dialysis, you need more and more. The saving coefficient of dialyzer is a hallmark of the dialysis adequacy of the middle molecules, and you have a different low, high, medium cutoff, and high cutoff saving coefficient. When increasing the saving coefficient, you increase the molecules removed, and it is a criteria of how much the molecules removed between the middle molecule as well as the albumin. It is a matter of equilibrium between higher removal and less albumin loss. When you are using that, be ensured that with the time of dialysis, you may lose some of the sieving coefficient by protein layer. So usually the sieving coefficient affected after 1 hour of dialysis session. Also, the molecules changed from linear molecule to globular molecule. So the linear molecule is removed better than the globular molecule, whereas the albumin is more linear. So albumin is, is high if you are using a very high membrane porosity. So this is the sieving coefficient of high flux, medium cutoff going to the right, high cutoff moving as well to the right, and the albumin loss during dialysis is limiting to be less than 3 grams per session. So the membrane sieving criteria is also an important to ask about that when choosing the dialyzer. Improving the blood flow as well will increase the clearance. So you have to test the dialysis adequacy as well. So the high cutoff membrane, I think it's not in common use because the albumin loss here is more than 7 grams. With severe pack filtration, you may have an endotoxin transfer and this induce pyrogenic reaction. Always use a machine with feedback control to control the dialysis adequacy and time. Coming to the end of dialysis, hypersensitivity is well known as phenomena of type 1 hypersensitivity induced, and this may be to any of the dialyzer or the portfolio circuit. The publication is high from the beginning up to now. Still, we have seen a lot of hypersensitivity reaction with anaphylactide reactions, urticaria, anaphylaxis, or any other types. And it has a criteria usually in the dyspnea, itching, pruritus that may be induced within the first 20 minutes from the beginning of the hemodialysis session. Considering hemodiafiltration criteria for a dialyzer selection, you need very big surface area and very importantly that effective blood flow should be optimum and the blood volume processed be optimum, so increasing the QP to higher level. You can use that above 350. With higher filtration fraction, you can have clotting and protein clouding. So a dialyzer specifically for hemodiafiltration is required to have a good sieving coefficient, higher ultrafiltration coefficient to maintain that without increasing in the transmembrane pressure. So using the machine in automated mode, you can have the maximum QF. If you have a vascular access weakness or small dialyzer or shorter time, you have to revisit your hemodiafiltration prescription. So this is the filtration fraction, importantly to have the maximum ultrafiltration against transmembrane pressure in hemodiafiltration, and this filtration fraction should be optimum. And if you increase the dialyzer surface area or the dialyzer ultrafiltration coefficient, you will have a lower filtration fraction if you increase the QP. So the dialyzer limiting factor for hemodiafiltration is limiting for high volume of online hemodiafiltration, so increasing the dialyzer surface area as well as the internal diameter should be at least 200 micron to improve the dialysis performance during hemodiafiltration. Use more hydrophilic, use more, of course, higher ultrafiltration. Usually the dialyzer flow KOF should be big, and we have above even 2.2, like 2.4 or 2.6, with an internal diameter more than 200 micron, with a sieving coefficient preferably for beta 2 should be above 0.6 and preferably to be above 0.8. Use large needles, and you can do post and pre-dilution in that way. And hemodiafiltration, high efficient with larger dialyzer, more hydrophilic nature, and higher ultrafiltration, so decreasing the transmembrane pressure, and you can have the high efficient one of hemodiafiltration therapy. So at the end, more patients are still coming for the hemodialysis journey. It's expected 5 million on 2025, pushing toward a dialysis better we are seeking for, and thank you very much.